Sicer pa v konceptih integrirane oskrbe diabetesa, kot smo slišali prej gospo iz Svetovne zdravstvene organizacije, ne razmišljamo samo v Sloveniji, ampak povsod po svetu in o njih bo spregovoril tudi naš portugalski gost, profesor dr. Filipe Raposo iz Svetovne zdravstvene organizacije. Profesor Raposo, welcome.
Thank you so much. So, bom dia, that's the Portuguese for good morning. And it's an international conference. I'm sorry I don't speak Slovenian. As it was said, I'll have to speak in English, so it's another moment in English. I hope you'll understand me. As Dr. Darina was saying, the slides, the presentation will be in Slovenian. I have here my slides also in English, so I can not get lost in the process in between, so I hope this thing will work. First of all, I would like to thank you for inviting me. I felt very honored to be here. And thank you for the Ministry of Health, for the Institute of Health, and for the WHO support for bringing me here. Again, it was my pleasure. It's really my pleasure to be here. As you see, my name is Joao Filipe Raposo. I'm coming from Portugal. I'm not part of the health ministry. I'm part of the Portuguese Diabetes Association. That's APDP there. So it's a patient association. It's a different patient association, and I can discuss that later on if you wish. I'm also vice president of the Portuguese Society for Diabetology. That's the scientific society in Portugal. And I'm a professor in the public health department of the Nova Medical School. That's one of the medical schools in Lisbon. And that's my background. And we'll follow up. And so the first point, I think it's also important, a part of the things I've said, to explain a little bit who am I and why is that can be important. And who am I, it's in the relation with the Portuguese Diabetes Association, so you can understand why did it surge in Portugal many, many years ago. And so it's the oldest diabetes association in the world. It was founded in 1926. I don't know if you knew that. And the story is, let's see if it's working. Yeah. I'll just put all the three here. And it started, the name you can see there, it's the Diabetes Association for the Protection of the Poor People. That was the original name. And so, as it was said in the beginning by Dr. Darina, it was always about that. It's always to get the treatment to everyone, the richest and the poorest. And so the story was that in 1926, insulin was very expensive. And so poor people couldn't afford because there was no national health system, there were no national insurance. And the founder of APDP, that's the man there, it was Dr. Roma, he had been in the United States shortly after the appearance of insulin. And when he returned to Portugal, he realized that poor people continued to die without access to insulin. And so he decided to fund this association for the protection of the poor people. He got the money from the merchants in downtown Lisbon, and he gave the insulin for free for the poor people with diabetes. And he was coming also from the psychiatrist. He was a psychiatrist resident, and he decided to integrate the concepts of respecting the poor people, educating them to treat themselves. And that was the beginning of what we call now education of people with diabetes. And for that, again, you can see on the top, but that's the Portuguese that was written in 1925, something about the conceptual framework in the association. And so what's written there, I hope, in the translation, is in diabetes, in this illness, the doctor must be a teacher more than in any other illness. So at the time, we have to change from the acute model where doctors or healthcare providers told the patients what they do to educate them what they should do for the rest of their life. And that's something that had to change a lot. The second point here is his job was not so much to treat the patient, but to teach him how to treat himself. And finally, he has to explain the basic ideas about the physiology of the illness so that the patient can understand the therapy. And putting all this, you can see here that we have to change the role of the healthcare providers we had to put education as a strength. That's really the main focus of our activity nowadays. And we had to provide education in a structured approach. And so that's something that was very different. We are speaking about 1925, so 90 years ago. And so with that, we started a new approach to diabetes. The customary doctor-patient relations had to undergo changes. And the diabetes patient needs to have understanding of this illness so as to appreciate the problem that could arise and learn self-treatment and control. And that was really the important thing to teach the patients. And only the patient himself, after due instruction, could administer and control all of the treatment. And that's something that's still very difficult for the healthcare providers to learn this, how to do this in the proper way. And that's the reason, so let me just put it here, because that's something that we are still discussing today, and I think that's the reason we are here in the 8th National Conference on Diabetes, because the paradigm has to shift, still has to shift. And what we called education 90 years ago, it's what we are discussing nowadays about empowerment, patient activation, patient engagement, health literacy. Sometimes the terms are changing, but we are always speaking about the same things, and that's also very important, okay? So the key points for today is to discuss a little bit about integrated care versus what we call multidisciplinary approach. They are related, but they are not exactly the same things. So I had to put the patient perspective on this side, and just as a final comment to discuss if diabetes care, is it going to be better or not for the future? And that's what we are speaking about. And then I hope we'll have some time in the end for questions and answers. And so we are discussing today something that's very different, and that happens, this is results in the United States, but it's everywhere, it's almost the same. The causes of death had dramatically changed in the last century. As you can see on your left side, the column there, we could see that in 1900, pneumonia, influenza, tuberculosis, gastrointestinal infections represented more than 50% of the causes of death. Nowadays, on the right side, you can see that not only we have gained health results because people are dying less of those causes, but heart disease, cancer, and a lot of non-communicable disease are really the causes of death nowadays. So that's why we call here the epidemiological transition. And the question here is, are the same process of care adequate for those two scenarios? Because when we decided, when we were acting on the left side, we had all those structures that really worked. We can see the results. But now the pattern of disease is different. Now it's diabetes, cardiovascular disease, it's cancer, and even some infectious disease are now chronic diseases. And so we had to change a lot on the process of care. Because this is really changing what was happening. We were always speaking about we were gaining years of life expectancy. People were living longer, and ideally they were living longer and healthy years. But now, this was in the New England Journal of Medicine a couple of years ago, there was a potential decline in life expectancy in the United States in the 21st century because of those non-communicable diseases. So this is really a threat to every one of us. And that's the point here. It's just not a question of spending money. And I would like to show you this slide. It's by the World Economic Forum, because it's not only the individual perspective of living non-healthy years or shorter life expectancy, but it's really a threat to the economy of the countries. And so what we can see in the left, it's a little busy slide here, but let's see, yeah. So here it's the likelihood of these events to happen, and this is the severity of those events. And those threats are the economic, geopolitical, environmental, societal, and technological. And this was in 2008, and there was the perspective for 2009, and the likelihood of asset collapse, that's the financial crisis that was going to happen, and they said it was very likely to happen, and it was a threat to the countries. Of course it was. But chronic diseases were just considered here as a threat to the countries. So they said chronic diseases is a threat because it's very likely to be a major issue for all the countries, and it's very, very serious. Okay? So it's not just about health for the Ministry of Health, it's about the survival of the countries because it's really a threat to the countries. And the other thing we had, and this was like 2 weeks ago in the Lancet, the good news on non-communicable disease is that policymakers have both an awareness of the problem and appetite for change. Unfortunately, this is not parallel with action. And so everyone is speaking about nowadays non-communicable disease. That's the first step. The second step is to adopt policies on that. And many countries have now adopted policies on that. The third step is to act, to change. And that's more difficult, of course. And I know the topic for this conference this year is about integrated care. And something that I was asked for, and I was happy to do that, is to discuss what is integrated care. Because if I ask each one of you what's integrated care, probably you would say different things, because we have all different perspectives on that. And I've been part of many international forums on discussing this integrated care, especially at the European level. And of course, each country or each organization has a different approach to integrated care. And most surprising, everyone is saying they are provided integrated care. I think 99% nowadays say they are patient-centered. But then if you ask the patients, I don't know if they all agree with this patient-centered approach. And that's the question also. And so I think you all have the access to that document I've shown from the WHO Europe about integrated care, an overview. And many of those things here, they are on the document. And so the first thing, it's about integrated care, and to tell you that there are different perspectives. So each one of these actors, of these stakeholders, they have different perspectives of what they called integrated care. And so we have the healthcare professional, we have the provider, we have the policymaker, we have the regulator, we have the evaluator, we have the community, we have the manager, and then you have the user service, the carer. And that's where the patients are, or the families, if you wish. And so it's just another perspective on that. And that's the reason also why it's so difficult to just consider the patient perspective, because there are many, many different stakeholders in the process, okay? And the first point when discussing integration of processes, it's to ask them, what perspective are you using, okay? Because they are really different. And that's there. And so on the same document, you have several definitions, possible definitions. And so the mechanistic definition is this one here. And that integration, it's a coherent set of methods and models on the funding, administrative, organizational, service delivery, and clinical levels. And that's, I think, most of us can understand that, because that's just an articulation process between different levels of care, process, and give the funds. But it's designed to create connectivity, alignment, and collaboration within and between the cure and care sectors. So it's about the health sector. But it's a little bit more, because we have to articulate, because we want to enhance quality of care and quality of life, and so we have to measure the consumer satisfaction and system efficiency for people by cutting across multiple service providers and settings. So we'll have an articulation process, we have connectivity, alignment, collaboration, but the purpose is to enhance quality of care, quality of life, consumer satisfaction, and system efficiency. And so these results will lead to benefits for people, and the outcome can be called integrated care. So this is a full comprehensive definition, I think. It's complex, so it's not easy to work on a daily basis because there are many, many different aspects that we have to check if we are applying them to integration care. The easiest definition is the patient definition. And so what we can say that was used in the UK, it's using the patient perspective. And so you would say, my care is planned with people who work together to understand me and my carers. They put me in control, coordinate, and deliver service to achieve my best outcomes. So again, this is much more simpler than the previous definition. It's about the patients. But we have to say, how can we measure that? Because it's my care, so we have individual care process. It's with people who work together. We are speaking about the healthcare providers, and we have to measure if they work together and if a patient can assess that. And those healthcare providers have to understand the patient and the carer, the family, or whatever the care person is. They put the patient in control. And that's about the literacy aspect. How can a patient know if he is really in control? Can we teach them to be in control and to coordinate and deliver service to achieve my best outcomes? What are those outcomes? And WHO Europe, in that concept paper, changed a little bit. So it's about integrated care, but it's a health system-based definition. So again, let's put the perspective on the health system. And so integrated health service delivery, that's what we are measuring or defining, it's an approach to strengthen people-centered health system. So it's people-centered health system through the promotion of comprehensive delivery of quality services across the life course. So it's through the life of patients. It's designed according to the multidimensional needs of the population and the individual, and delivered by a coordinated multidisciplinary team of providers working across settings and levels of care. And so you can see here the multidisciplinary team or the multidisciplinary approach is just a part of integrated care. So sometimes it's very easy to say, well, in my health center, I'm a doctor, I have a nurse, I have a nutritionist, and so we are providing integrated care to people. That can be true, but most of the times it's not true, because they are not respecting all the previous steps that I'm putting there on the place. And so this integrated health service delivery should be effectively managed to ensure optimal outcomes. And so the first question, another question I have to ask you, what's an optimal outcome? So because it's A1C for people with diabetes, that's the optimal outcome, is dying less retinopathy, less blindness. It's not easy. I'm also part now of an international group discussing what the patient-related outcomes in concerning with diabetes, and it's not easy at all. Because again, each patient could have their specific needs, and the outcomes they value most is not exactly the same as we healthcare providers define as most important. And again, this service delivery should manage to appropriate use of resources based on the best available evidence with feedback loops to continuously improve performance and to tackle upstream causes of ill health and to promote well-being. And so these are also very fundamental aspects because it's quality-driven, it's evidence-based, and it's continually assessed. So we want to evaluate what's happening, analyze the data, and define changes for the future. And that's also the process that you are doing here, and that's the best way to do it. And for that, and now on diabetes and integrated care, you have to do that intersectoral and multisectoral action. So we are not always speaking about health services. We are speaking in health in all our daily life. And now it gets more and more complex. We are also about putting models of integrated care, and it's a little bit about creativity because each one of us has an idea about it, and we can also always design it. And so for models of integrated care, I'm just putting here, we can have, again, different perspectives. We have individual models of integrated care, and those are the models about case management, individual care plans, patient-centered medical home, or personal health budgets. Just to tell you shortly about two of those. In case management, you have just to assign, we have a case manager person, so it usually could be a nurse, but even could be a not health-related person, and he is the manager of a person with diabetes. And you will deliver, you will articulate all that care so the person can get the best treatment. As you can imagine, having this case manager can get very expensive also to have the best treatment for that. And so the idea is not to have case managers for all the diseases, for all the process, but each health system would define which case should be managed by these specific persons. Okay? The personal health budget is also a nice concept because it's just to say, well, if you, these people, this person has a budget for this year. And so you would spend the best way this money on health. So what happens with that? People have to know what's the best for him. They have to know what's the best treatment for him and to use with judgment the best of his money. And so it's not easy to do that. So that's why they decided to also to do it in a different way. And so nowadays we are discussing the models of integrated care for specific groups like the elderly, the frail, and there is another WHO document about integrated care specifically for the elderly, but the concept applies for many others. And we are discussing also models of integrated care for specific diseases like diabetes, asthma, and others. And so for those, we have community focus, we have health system focus, delivery system design, self-management support, decision support, and clinical information systems. And we'll follow with this one. So one of the best now is this one, the chronic care model. It's like we have here the community and the health system. We have resources and policies, we have the healthcare organization, and then we'll have to provide self-management support. We have to deliver, and we have a good design of system delivery. We have to have good support to decision, and we have to have those systems that provide information, clinical information. With that, at the end, again, we want to have improved outcomes, and that's the difficult part, because sometimes it's very easy to design a process. It's just a question of putting and say, you have to speak to this person, and this person has to speak to another one, and so we have a new process. But then we have to assess that process, and to assess this process, I have to say, at the end, we have an improved outcome. Otherwise, we don't want to change. It's not need to change, okay? And for that, at the end of this, if this works well, you also have informed, activated patient, or educated patient if you want. And for the team, we have prepared team, proactive teams, and they really are keen to do it. So it's, again, a balance between the healthcare providers or the team and the patient side. And it's not easy to do that. This one, it's the innovative model about chronic disease. It's something that have evolved from the previous one. Again, we have the positive policy environment, you have the community level, you have the healthcare organization, and so we have, again, motivated healthcare team, you have a preparedness of the environment, and we have community partners informed. Again, at the end, we have better outcome for chronic diseases. And so, apart from that, we have what we call population-based models, and it's usually 3 examples of that. The Kaiser Permanent in the United States, the Veteran Administration, again in the United States, and the Basque model of integrated care. And just to put you an example, in the Kaiser Permanent, what they do, they stratify the population they serve, and so we'll have measures of promotion and prevention for the general population. They provide support to self-management for chronic patients. It's like 70 to 80% of the population. Of course, those patients sometimes they get sick, really sick, and so we have illness management for high-risk patients, 15%. And the case management approach is given to patients with severe complications, and that represents less than 5% of the population. And so, as you can see, we can mix all the models and choose the best of them, but we have to know that also. And so, let's go back to the patient perspective, and I want you to share with you something that I've read many years ago, and I think it's still useful for me. It's for Marguerite Yourcenar, the Memoirs of Adrian. It's a book she wrote like if she was the Emperor Adrian. And the emperor has been to the doctor on that day, and what he said, it's difficult to remain an emperor in the presence of a physician, and difficult even to keep one's essential quality as man. The professional eye saw in me only a mass of humors, a sorry mixture of blood and lymph. And so we are always trying to segment the patients. So it could be diabetes and cardiovascular and asthma, but in diabetes we can split them in A1C, hypertension, and lipids, and then we can split in the glycemic control and monitoring, insulin pumps. So we are always splitting the person in different compartments. And that's so difficult for the patients to understand why we do that. And so we came to the concept of expert patients, and that's a definition used by the British Medical Journal. And so we should have expert patients. So these are the people who have the confidence, the skills, the information and knowledge to play a central role in the management of life with chronic disease. And so the main task nowadays of the health system is to train patients to be expert patients. And so we have to spend some money on that, we have to spend some resources on that, because otherwise we are always discussing the patient involvement in the process, but they are not really the expert patients that we need, because they are the most responsible ones in the process. And for that I came to the term of patient education. That was from a WHO working group, 1998. And the definition about therapeutic patient education, it's educational activities that are essential to the management of pathological conditions. They are managed by healthcare providers. They should be duly trained in the field of education, and those activities are designed to help a patient or a group of patients and their families to manage their treatment and prevent avoidable complications while keeping or improving their quality of life. And so we'll have to have a set of activities. We have healthcare providers trained in the field of education. The idea is to help patients to manage their treatment, prevent complications, and something that sometimes we forgot, it's to keep or improve quality of life. Because if you understand what's treatment of people with diabetes, most people, after starting treatment, they feel that they have lost quality of life. And that's something that we are not so aware of, that healthcare providers. So treatment, those therapeutic patient education, produces a therapeutic effect additional to that produced by all other interventions. And so it's very important to be there, because when health systems pay for pharmacological treatment, they can discuss the price of their treatment, but they know that it produces a beneficial effect on the patients. But sometimes it's more difficult to discuss the payment for education, and education really works. So it's the same, it could be used the same model to pay for education as to pay for a medical treatment, a pharmacological treatment. Another thing, it's when we say the patient-centered, we have to put people needs as priorities. That's one example of needs, human needs, that's Maslow pyramid. And in this concept here, you just have to say that first people want to have their physiological needs, and then safety and love belonging and esteem and self-actualization. And those are all the needs that we all in this room need to be fulfilled. And if you have threats on these basic levels, it's no use to go to the top level, because the basic ones are not fulfilled. And diabetes really, it's a threat because it's all around the basic needs, because it affects food, water, sex, sleep, homeostasis, excretion. And so all the basic needs are threatened by diabetes. And sometimes we are just addressing the people at the top here and forgetting the bottom. Again, I was speaking about the patient-centered outcomes, and I have an example here about the working definition, and it's to train the patients to ask these kind of questions that you can see here. So imagine patients arriving to the doctors or to the nurse and say, given my personal characteristics, conditions, and preferences, what should I expect will happen to me? What are my options, and what are the benefits and harms of those options? What can I do to improve the outcomes that are most important to me? How can the healthcare system improve my chances of achieving the outcomes I prefer? Most healthcare providers are not trained to answer those questions. And so sometimes we train the patients to do these questions, but then we are not able to answer them. And so I think we are not ready to do that. Diabetes is increasing, and you know the numbers here. And just passing here, and it was also mentioned before that we have those goals to achieve a 25% relative reduction in the overall mortality from cardiovascular disease, cancer, diabetes, or chronic respiratory disease, halt the rise in diabetes and obesity. At least 50% of eligible people receive drug therapy and counseling, including glycemic control, to prevent heart attacks and strokes, and those are really the difference. IDF presented this last 2 years ago, saying that diabetes in the world causes 5 million deaths, HIV, AIDS 1.5, tuberculosis 1.5, malaria 0.6 million. And it's just here to represent that sometimes we don't have that idea of diabetes is causing death. It's a global threat. And sometimes we say, okay, cancer is really the worst thing that can happen to people, and that's the relative risk of deaths at 5 years. And what you can see is prostate cancer, breast cancer, Hodgkin disease, but then you have neuropathic ulcer, much death risk than the other ones. Amputation, when a patient has an amputation, the risk of death in the next 5 years, it's increased. Then you'll have cancer, colon cancer, but ischemic ulcer, it's worse than colon cancer. Peripheral arterial disease is worse than the other one. Only lung cancer and pancreatic cancer are worse situation. And so again, it's just we have to transmit that idea that diabetes is a very serious condition. It's not just about a little bit of sugar in the blood. And coming almost to the end, just to tell you, there is a lot of research on diabetes. That's for type 1 diabetes, you have more than 2,000 studies now. For type 2 diabetes, you have more than 6,000 studies running now. But there's always the concept of the drugs. What's really innovation? We are always discussing, at least in my country, we should have the new drugs on the market, but we have to discuss also if they are new, innovative, if they are an adding value to the system or not. Because most of the time, as you can see here, they are just combination drugs and me too drugs, so that's not really innovation. Results in diabetes are better. So we have less complications in the world. This is in the United States, but it's everywhere almost the same. It's not exactly the same for all the complications, but it's getting better. But just not to forget that we are causing psychological problems to people. And this was written by a psychologist in 1995, and it was like a kind of recipe, how to cause psychological problems. And the first thing to cause psychological problems is to diagnose a chronic disease to someone. It's really causing problems. If you are unclear about the cause of this disease, but implying some hereditary component, you get worse. If you say that the treatment is important, but it's time-consuming and painful, if its management affects the life of a family, if self-control and self-management are important, if terrible results of an unwise lifestyle happen, if healthcare professionals are uncertain about treatment goals and regimens, and health professionals give contradictory information. And that happens a lot with us. If you see that, it was not specifically designed for diabetes, but that's true for diabetes. So we are causing psychological problems for everyone. Nowadays, we have a lot of innovation, technology, social media, and sometimes it's very easy to us to say, well, let's go on, let's adopt Facebook to put all the people in connection. And that can be true or not true. The introduction of technology could be good or not good. And governments and systems sometimes are spending a lot of money just on the new technology, on the new virtual media, and still a lot of research has to be made so we can assess the results. And that's a study published in 2015, and I'll go on. And again, the last concept is about adherence. We are always speaking about patients are not adhering to therapy. And we are always trying to find solutions. And what I'm showing here, it's this man received an award for something that supposedly increased the adherence of patients to taking their pills. And so it's a system where you'll have the pills on this box, and it's connected to your phone, mobile phone. And so everyone knows if he's taking the pill or not. And really, you can say, okay, that's a fantastic solution. But of course, it's not a fantastic solution. It's much better to invest in patients and to explain him what he should do, what that pill is important. So for sure, you won't forget if it's important, because he's not forgetting any other things in his life. And the last thing, it's patient what they really need in diabetes, and we are not providing it. Well, people would like to be cured, because that's the model of disease. And so we are supposed to give the cure for the people. And so we have to deal with frustration. And then when we are speaking about outcomes, the ideal outcome for diabetes would be the cure for diabetes, and we are not providing it. And so we still have a lot to do. In diabetes 2030, diabetes will increase, the numbers of people with diabetes will still increasing, and the costs will be rising again. And so, to conclude, people with diabetes will have the solution. And so, patient empowerment programs are really important. Public health has not to deal just with tight glycemic control on the population, but to start upstream to prevention measures and to change society. And that's also the integrated care model. We have to take care from this part here, from the national health insurance to the tight glycemic control. We have to spend money and design policies across all that spectrum there. I don't have the time for that now, but just that's to say that people in economical, they are studying also what happens in health. And that's from Michael Porter in the United States. He was discussing the problem in the health, saying that people are receiving less money, healthcare providers are receiving less money, with worse health outcomes for the population. And so he said, we'll have to change things, and we'll have to to have this kind of model, that's integrated practice unit, that's what we are discussing here. And so we'll have integrated practice units, measure outcomes and costs for every patient, move to bundle payments for care cycles, integrate care delivery across separate facilities, expand excellent services across geography, and all this has to be supported with information technology platform. In Europe, we are discussing that. That's the CRODIS Joint Action Program. It was about health promotion and chronic disease prevention, and it has evolved to this one here. That's the CRONIS Plus Joint Action. It just started last year, and Slovenia is part of that, and you can see it's in this work package 7, and the idea is to improve the quality of care for people with chronic disease through implementation of quality criteria and recommendations tool, and we have to evaluate the applicability and transferability of the quality criteria and recommendations across the countries. And I know that in Slovenia, we'll have the demonstration of this model between the cooperation of this hospital and the primary health center. And so they will be demonstrating that this kind of model of integrated care for a specific condition, chronic wounds, will work. And I'm going just to tell you that prevention is important, as you have heard before me, and there are different models for prevention. We can have taxes, retail policy, workplace health promotion, community dietary advice, but we are doing in Portugal intervention for individuals at high risk. I'm not just, I'll have to skip it because I'm running out of time, but it was a challenge that we have assumed as a national challenge. That's the name of the program, No to Diabetes. And so the idea is to prevent the growing epidemic of diabetes in Portugal. And it has a lot of, I'm just going to the implementation process to say that's a primary prevention program that really has a lot of different stakeholders in the process. You can see that my association, it's there, the APDP, but it's about private foundation, non-for-profit, but it's about health ministry, community, health structure, all working together, which is a challenging process, I must tell you, to work for primary prevention. Again, it's like putting primary prevention of diabetes, not on the health structure, but at community level. I'll go to that part. You have seen that before. And to conclude, I told you that I want to discuss with you if diabetes is going to be better or worse. And the first theme, it can be better if we have, it's quoted there, if we have cooperative teams englobing patients and family. It could be worse if we have uncoordinated and very directive teams. If we have population-based screen, diabetes could be better because then we'll have resources for applying. If we are just doing opportunistic screening, diabetes for sure is going to be worse. If we identify pre-diabetes, it's good. If we have no strategy for pre-diabetes, then diabetes for sure in the future will be worse. If we have adopt strategies for, if we have strategies for social determinants, of course, diabetes will be better. If we are just strategies for individual responsibility, then it will be worse. And finally, if we have clear political support, that's good. If we have isolated measures, it's not going to be good. If we have sufficient resources, that's going to be good. But if we have insufficient resources for that strategy, that's going to be worse. And if we have integrated systems with outcome-based incentives or any other bundle payment, that's going to be good. If we have strict compartment care based on process or in complications, diabetes is going to be worse. And if we integrate innovation with new models of finance, then it's going to be good. Otherwise, it's going to be a threat. And that's it. Thank you so much.
Thank you very much.
Keeping the time.